Hello everyone, I would like to welcome you on this exciting session, also on behalf of my co-chair, Professor Ian Graham. The session on SCORE2 and SCORE2 Op risk algorithms to estimate cardiovascular disease risk. This is going to be an exciting session with a great lineup of speakers. Martin Holland will kick off with an introduction. Lisa Pennels will update on methodology. Emmanuel Dianz Antonio will discuss the new SCORE2 algorithm. And Dr. Stephen Hageman will discuss the SCORE2 Op, older persons risk score. And my co-chair, Ian Graham, will end with some concluding remarks. I think it's great that we can build on a large body of evidence and the legacy of the SCORE algorithm already around in clinical practice for over a decade. And this session is really about an update of these new algorithms.
Frank, thanks very much. I will talk about the SCORE2, SCORE Op, the risk algorithms. Let's really congratulate here Emanuele and Ian for publishing these great manuscripts. And it is on the one side, to the left, it is the SCORE2, the new risk estimate, 10-year risk estimate in Europe. And then on the right side, it is the basis that we want to transport on the systematic coronary risk evaluation as it is done by the SCORE. Well, why do we have risk scores? I mean, it's evident in cardiology. We want to assess the individual risk, and it's a fundamental component in preventive cardiology. Apparently, most healthy individuals, the risk of future cardiovascular events is not clear, but it is becoming clearer when we use risk scores as the combination of several risk factors. And reliability is important to assess the individual patient's cardiovascular risk, particularly also in the young as well as in the older ones, and also in subgroups which we have addressed. We do know that there are risk assessment tools all over the globe, but the SCORE is what we will focus on today, which has been launched and published and is excitingly presented today. The vision is by contributing to the mission of cardiovascular, by EC, the reduction of cardiovascular disease, is a research collaborative approach looking at new aspects of cardiovascular risk estimation and developing practical implications particularly. And the means is coordinating the collaboration of experts with diverse but complementary skills. And this is done by the Cardiovascular Risk Collaboration Group, which is situated in the European Heart Health Institute. Well, the rationale I pointed out, the most cardiovascular disease is the result of the combination of risk factors. We know, though, that current systems are crude. We know that audits have shown that risk factor control is poor, so we have to develop something more than that. And the coordination of expertise is needed among different stakeholders, particularly also outlined here in cardiology, the associations, the clinical trial experts, IT, genetics, imaging experts, and so forth. But not only assessing cardiovascular disease risk, but also other entities in cardiology. And this is why the cardiovascular risk collaboration structure has been developed, assessing risk, getting all these data together, including genetics, imaging, big data, and then looking whether a new SCORE and the SCORE Op will then be eventually lead to a reduction of cardiovascular disease in Europe. Thank you very much for your attention.
Thanks very much, Martin, for this kind introduction. And I will hand over the mic to Dr. Lisa Pennels from the University of Cambridge to present the methodology behind the two scores.
Thank you very much, Frank. So my job today is to describe some of the key methodological aspects that underpin both the development of SCORE2 and SCORE2 OP, before handing over to Emanuele and Stephen, who will give you much more detail on the specific scores. So I'll start with some general background. So CVD risk prediction models are an integral part of guidelines for primary prevention of CVD. And to echo some of Martin's introduction, these models integrate information on several CVD risk factors to estimate a person's risk of a CVD event occurring over the next 10 years. And these risk estimates are used to identify people at higher risk of an event who might benefit most from preventative action. Regular recalibration of CVD risk scores is important to ensure that the estimated risks from these models really reflect the current level of risk in the population. And this last statement really refers to a key aspect that we've included within SCORE2 and SCORE2 OP. So before I go into the details of this recalibration approach, I just want to outline the key building blocks, if you like, of 10-year risk prediction models. So there are two key components. Firstly, the baseline risk, which represents the average level of risk in the population. And secondly, the relative risks, which are our risk ratios that tell us how much risk increases or decreases with levels of the included risk predictors. So when we make a person's individual risk estimate, we take essentially that population level baseline risk and we scale it up or down according to the relative risks and that person's measured risk factor values. So bearing those two components in mind, if we think about how transferable prediction models are across different populations, for example, different countries within Europe, or how relevant they are after a period of time has passed, we know that those relative risks, those risk ratios for CVD risk factors are very similar across different populations, and they've actually remained pretty stable across many decades. So a model derived in one population should discriminate equally well in other populations or in the same population after a period of time. So it should rank people similarly well in terms of their risk. However, the baseline risk varies enormously with the population and also with time as CVD event rates go up or down. And importantly, this variation is not completely explained by the risk predictors in the model. So it may depend on other population characteristics, such as the quality of healthcare, the economic situation, for example. And what this means is that a model derived in one population may systematically over or underestimate risk in a new population or at a later time point. So it may be poorly calibrated. And adding to this miscalibration concern is that these models are typically derived in cohort studies, and by nature, cohort studies tend to represent a past period of time, and they may represent a subset of the population, either by design or due to biases such as healthy volunteer bias. So whilst relative risk derived in cohort studies are really valid, the baseline risk may not be representative of the target population for screening. So this is why we think that regular recalibration of most CVD risk models using nationally representative incidence data is really needed. And with this in mind, we've included a recalibration step in our risk score development process. So this is the general process for development of SCORE2 and SCORE2 OP. We started by deriving models using prospective cohort data, and then we've recalibrated using representative incidence rates and risk factor values from each target population. And then we've gone on to do some external validation in other cohort studies, and then to illustrate some of the risk predictions that you get using the recalibrated models in different countries. So in terms of the recalibration, SCORE2 and SCORE2 OP have currently been recalibrated to 4 different risk regions within Europe, and these risk regions are defined using WHO CVD mortality rates. And this slide outlines the recalibration process and how it works. So we think this is a reasonably simple process which will allow regular updating in the future with changing trends in CVD epidemiology. And importantly, it requires only aggregate level incidence estimates and risk factor values. So it can be essentially applied using routinely collected data. So it works by taking our average risk factor values within 5-year age groups in our target population and plugging those into the core uncalibrated risk prediction model to get a predicted 10-year risk for each 5-year age group. We then take our annual incidence estimate for each age group and extrapolate that to get an expected 10-year risk. Having got these across age groups, we can relate expected to predicted risk and calculate recalibration factors, which are then used to rescale every new risk prediction to get a recalibrated 10-year risk. So, of course, the success of this approach relies on having good risk factor data and incidence estimates for our target population. And this slide tells you a bit about where those estimates have come from. So risk factor data comes from the NCD risk factor collaboration, which represents all countries across Europe. And our incidence estimates are calculated starting with WHO's CVD mortality estimates, which are then converted to total CVD incidence using region, sex and age-specific multipliers. And this is a two-step process where we take that annual CVD WHO mortality and translate that to get a 10-year mortality risk. And then we calculate our multiplier using individual participant data, this time from each of our target regions. And this is calculated as the ratio of the 10-year risk of a first CVD event in participants with no prior disease to the 10-year risk of a CVD mortality event in the whole population. So this denominator mimics the WHO mortality that we get for the population. So you can see once you apply this multiplier to our 10-year WHO mortality risk, we get an expected 10-year risk of a first CVD event. Also, really importantly, these two steps include a correction for competing risk of non-CVD death. So this avoids us overestimating risk in countries where there's high rates of non-CVD deaths. So this slide just shows you how that recalibration has worked. So we can see we have the uncalibrated risk predictions shown over age by the blue line, and these agree really nicely with the expected 10-year risks shown by the green line in our low risk region, but they progressively underestimate risk as we move up through the risk regions until we recalibrate, and then we have this red line which now agrees really nicely with the expected 10-year risk in each region. So as a summary, SCORE2 and SCORE2 Op have been developed with this integral recalibration step, which can be applied using routinely collected data. And both scores have been recalibrated to estimate risk of total CVD, so fatal and non-fatal CVD in 4 risk regions of Europe. And these recalibration methods can be applied readily in the future, either to provide country-specific recalibration, but also to provide updates with changing CVD rates. And I will finish there for some discussion.
Thanks very much, Lisa, for providing this clear overview of the methodology. So we have time for a discussion, a few questions, and maybe I can kick off. So you present a methodology where you're able to regular update and recalibrate risks. So when you think about regular, how regular is it? Yearly or every 5 years? What do you have in mind?
It's a really good question. I think the beauty of the fact we're using annual kind of mortality and incidence estimates is that we can assess using those annual rates whether rates have substantially changed. And if they haven't substantially changed, there's no need for an update. So it's a question of really wait and see and what happens in terms of CVD rates in the future. It's a slightly non-committal answer, but the methods are flexible.
Yeah. So any questions from the faculty?
Can I ask a question, Lisa? When we looked at this a few years ago, we got into some difficulty with the multipliers. Firstly, because the quality of the non-fatal event data were variable, and you've done your best with that, but also because with very low risk populations, the relative risk can be very, very high because of the low case fatality. Would you like to comment on those aspects?
Sure. So I think the multiplier estimates we've tried to use the most reliable data sets within each region. And we've got fantastic data sets from Finland, Sweden, the UK, which really cover the entire population and are made possible by having these personal IDs that are linked to several different electronic data sets, hospital records and registry data. So that's really enabled us to get a fairly, what we think is an accurate estimate of the non-fatal events and the ratio of those to the total events. And again, we've done some validation of that, where we've tested to see whether our derived incidences match that which we see in other external registry data sets. And they do seem to match pretty well where we've been able to obtain that data. But you're right, that's a really challenging aspect of this work, is getting those non-fatal events. What was the second part of your question, sorry?
Oh, just that the relative risks in new, younger populations are very high because of the very low fatality in these populations.
Sure, so the multipliers are naturally much higher in younger individuals, and that's exactly what we've seen. You can see in the paper how they change dramatically with age, and we've allowed for that.
Very good, thank you.
Thanks, Lisa. Some more questions from the faculty.
Lisa, thanks for your great presentation. You said that the scores or the risk is relatively stable, coming over, like looking back to the last decade. So is lifestyle on the one side, you know, that's changing, pollution and so forth, is that also then not affecting cardiovascular risk? Is like, I would like to be a little bit provocative, or that we do have a lot of data on risk, and the other factors only of low risk?
So I think things like that would absolutely affect the baseline level of risk in the population. I completely agree. I guess my statement was more specifically to do with the relative risks. So the hazard ratios, the amount risk increases relatively with say a 1 millimole increase in total cholesterol. That relative risk has remained very stable.
Okay, thanks very much, Lisa. In the interest of time, we move on to the next speaker, and that's Emmanuel D'Antonio, also from Cambridge, and he will present the new SCORE2 algorithm. So, Emmanuel, please.
Well, thanks, Frank, for the introduction, and it's a great pleasure to be here to present the SCORE2 risk prediction algorithm on behalf of the SCORE2 working group and the cardiovascular risk collaboration. So just following off from what Lisa was mentioning about the importance of the ASCVD risk prediction algorithm as a part of the European guidelines, it's really that SCORE, the original SCORE, was actually part of the ESC guidelines for many years. It's been since 2003 when it was actually derived. It's been main part of the prevention guidelines and lipid management guidelines, and it's been really part of a key aspect of managing prevention. But of course, SCORE has in some way sort of made its time, and it's been derived with using several studies, but were recruited in before 1986, and actually has not being able to take into account many of the aspects that has been changing in terms of epidemiology of cardiovascular disease. For example, the shift from mainly fatal to actually non-fatal outcome, especially in younger people, and as well the fact that and I believe, for example, to take into account for other competing risk, and so the possibility of actually underestimate risk in young individuals and actually overestimate risk in older individuals. And so with this motivation, the SCORE2 working group and the CRC collaboration came together really to define and to develop the SCORE2 algorithm. And so this is similar to what Lisa presented. This is actually the model in which we have derived and then validate and illustrate the SCORE2. As you can see here, there are different steps in which we have defined our development. So the first one was really about the derivation of the cohort, and I'll just illustrate in a second which data we have been using. Then the second aspect was actually recalibrating to the different 4 regions in Europe, and here's again using the methodology that Lisa just outlined. And then the last 2 steps was really about how can we externally validate, and so show that actually SCORE2 works. And then finally, how can we illustrate the predicted risk for each specific country where we want to apply SCORE2. And so the first step, as I was saying, is really about the derivation of SCORE2. So to derive SCORE2, we have been using data from 44 prospective cohort studies that were collected in the Emergence Factor Collaboration plus UK Biobank. There was a total of about almost 700,000 individuals with about 30,000 events accrued over 10 years of follow-up. And really what we've run is really sort of a sex-specific competing risk model with including this kind of risk factor that are illustrated here in this page. And you can see that many of them, here you see the risk ratio for men and women. And actually, according to age, you can see that some of them actually change with age. So the inclusion of age as an interaction term was actually a key aspect of development of this score. And deriving that was the second step was really about the recalibration. You've seen already this map. This is the different four risk region that we've been using to develop, to recalibrate the score. And to allow this recalibration, we have been using data from several cardiovascular registries that actually allow us to calculate what we defined just before is the risk multiplier that allow us to transfer the data from WHO mortality to actually an estimate of total cardiovascular incidence. And these data were actually large and were spread across different regions in Europe. So these data are, for example, part of the CPRD dataset in the United Kingdom, data from Sweden, from the Swedish population data, the Finnish data, and then data from the Estonia Biobank, and as well data from the HAPPY study in the very high risk region. And so using this large amount of data, we'll be able to calculate the multiplier that then was applied to the mortality, WHO mortality for different regions, and then allow to recalibrate our regional model. And so once we calibrate the regional model, we came up with the risk prediction, the SCORE2 risk prediction algorithm. Here's just an illustration of that. These are the chart that have been published in the European Heart Journal just a few months ago. And here's just the simplification of that, in which we're using, rather than using total cholesterol and HDL, use actually non-HDL, but it's very similar to the full risk algorithm that actually will be available on electronic platform. And here's again sort of just an example of the risk chart for the medium moderate CVD risk region and the high CVD risk region. And so what happened when you apply these to different population, and here's in my slide actually showing what happened when you apply this to the four different region and actually to an individuals, an exemplar individual which have a systolic blood pressure of 140 milliliter mercury and a total cholesterol of 5.5 millimole per liter and an HDL of 1.3. And you can see that there is a difference, of course, according to age for the same risk factor, but as well there is a difference between region. And so here's in different color, you have men and women, smoker and non-smoker. You can see how the risk can vary both within and between different regions. So the next step, as I said before, was how does it perform in terms of discrimination and how that's performing in other cohorts. And here's a figure showing the C index, so a measure of risk discrimination that we have performed in 25 different cohorts that were not used for model derivation, including of about over 1 million individuals. And this is possibly one of the most extensive validations that have been produced for any risk score, especially in cardiovascular disease so far. And you can see that the C index was varying, between about 0.67 to 0.81, depending on different cohort, depending on different sites. But actually, on average, it was pretty a good discrimination for what we usually are used for cardiovascular risk prediction. And in terms of when we compare that with the original score, actually, this was showing an improvement as well in C index, about improvement with 0.01. That was actually more evident in younger individuals. And when further comparing SCORE2 versus the original score, we then compare sort of how perform in terms of calibration. So what happens if you use SCORE2 and original score in an actual population by comparing the calibration? And you can see that if you see the predicted in blue and the observed risk in red, you can see how the SCORE2 was much more closely aligned with what we observe in risk compared to what its original score was, in which was tend especially to over-predict risk in older population. And finally, just an illustration of how this score can perform. So here in different color, we have different risk categories going from less than 2.5 to more than 25% over 10 years. And you can see how here is we have defined the different region, not only the overall region, but actually the individual country within each region. And you can see how the risk, the distribution vary across different countries, pretty similar between country within the same region, but actually different if you compare region across region. For example, if you go from a low risk region to a very high risk region. So just to conclude, I think we have developed the SCORE2 risk prediction model using a very large data in terms of derivation that actually allow us to generalize our model and actually allow us to have a flexible approach to recalibration using actually data that actually are contemporary information for CVD incidence, actually CVD risk factor in for different region. And of course, the way that we have developed this, as Lisa explained, can actually allow us to re-update and remodel recalibrate our risk prediction model in future to really match what will be how the evolution in terms of cardiovascular risk trend will be. And actually, the SCORE2 and the SCORE2 Op that will just be presented by Stefan in a few minutes will be recommended by the ASC prevention guidelines that actually be presented later in this Congress. And thanks for your attention.
Thank you very much, Professor De Angelo Antonio, for a very clear discussion of how we have struggled over the past few years to improve SCORE in the way that you've outlined, and it's a great presentation. Rather than a question, just a comment. Our data collection systems are not harmonized at all throughout Europe. And just would you comment on Eastern Europe? Our high-risk countries are essentially Czech Republic and Estonia. So there's a real need for standardized and improved data collection in Eastern Europe and for the ESC to help these countries, I think. Would you like to comment on that?
Well, thanks, Ian, for this really excellent comment and really spot on what is the need, I think, for the next step. I think, during my presentation, I highlighted actually the wealth of data that we have for model derivation, and so the ability to derive risk factor hazard ratio for risk factor in a very precise and consistent way. I think what is really missing, and this is really should be part of our collective effort as European Society of Cardiology, as a really scientific community, is really to be able to collect reliable information from every single country. And there's clear evidence of missing data, especially for Eastern European country, in which actually being using to use some of the data. But of course, being able to access data for each diverse country will improve the ability to derive this score and actually to recalibrate in the future. So actually, I think we should really, as a community, as a society, we should really make sure that in the future we are able to collect data at the individual country level, reliable, that will allow actually estimation not only at the risk factor level, but as well of the incidence rate for cardiovascular disease.
So any other comments or questions from other members of the faculty?
Emanuele, just in line what you just answered, I know that you have thought or have many thoughts on this, combining the assessment of the risk by the score, as well as then by the individual entering her or his data on cardiovascular risk, thereby collecting data. So what are your thoughts on this way of...
Thanks, Martin. I think it's a very interesting point. I think there will be available of a website and as well app that will allow calculation of score, and actually as well SCORE2 Op for individuals, for clinician, for patient. And actually one of the key aspects for thinking about the future is how can you optimize use of data that will be collected through the system, because that can actually give us a real information about the snapshot of risk in Europe, in different countries, in different individuals over time. And so really will potentially allow us not only to look at this information but actually to improve our prediction. And so really in an iterative process in which we develop a risk algorithm, but as well we update, we monitor the use, and actually we monitor evolution over time and trend over time of risk factor and incidence rate. So I think by those combining those information that can be in some way collected of self-information from clinician and participant to what I was saying before to Ian, collection of reliable data from hospital registry, from different countries, would actually really can be able to move prediction forward and really with access to reliable data.
Okay, thank you. Well, we're dealing with an aging population in Europe, and one of the problems with SCORE1 was that it ran out of steam at age 65 to 70. and also overestimated risk in older people. So it's a great pleasure to ask Stephen Hageman to tell us how we address these issues with SCORE2 for older people. Thank you.
My name is Steven Hageman. I'm a medical doctor and PhD candidate from the University Medical Center, Utrecht. And today I'd like to present to you the derivation and validation of the SCORE2 OP risk prediction algorithms. My colleague, Tamar de Vries, is available to answer all of your questions in the chat. I will be presenting today on behalf of all my co-authors in the SCORE2 OP working group and the ESC cardiovascular risk collaboration. As you know, older persons are at the highest risk of cardiovascular disease, and the highest potential treatment benefit of risk factor reduction is in older individuals. However, cardiovascular prevention in older persons is challenging. One of the reasons for this is that older persons often have a limited remaining life expectancy. Often, many of these individuals also have comorbidities to take into account when initiating preventive treatment. Polypharmacy is also very common in this group. This group sees high rate of adverse events from preventive therapy. Therefore, an individual approach is needed to balance benefit and harm of preventive treatment. The benefit of preventive treatment can be estimated using prediction models. However, traditional risk models perform poorly in older persons. One of the reasons for this is that the effect of classical risk factors on cardiovascular disease risk attenuates with increasing age. Moreover, many traditional models do not take into account the possibility of competing events. Not taking into account the possibility of competing events may lead to overestimation of cardiovascular disease risk, and with that, overestimation of the potential treatment benefit. Several specific risk models have been developed for older persons. However, these have either not been extensively externally validated, or they only predict cardiovascular disease mortality, whereas non-fatal events are a very important part of the cardiovascular disease burden. And none of these models have been well recalibrated to all European risk regions. Therefore, we set out to develop and validate a competing risk-adjusted model for individuals 70 to 90 years old without pre-existing cardiovascular disease to estimate the risk of fatal and non-fatal cardiovascular disease in 4 European risk regions. The SCORE2 OP model was derived in the cohort of Norway. The cohort of Norway is a collaboration of several population-based studies from different regions in Norway. All individuals were included between 1994 and 2003. From this cohort, we use all individuals age 65 and older without prior cardiovascular disease. In total, these individuals were followed for a median of 13 years, using linkage to national endpoint registries. In over 300,000 person-years of follow-up, over 10,000 fatal and non-fatal cardiovascular events were reported. The primary outcome of the SCORE2 OP model was, just like the SCORE2 model, the risk of non-fatal myocardial infarction, non-fatal stroke, and cardiovascular mortality. This was predicted using sex-specific fine-grained competing risk-adjusted models. The predictors used were age, current smoking, total and HDL cholesterol, systolic blood pressure, and diabetes mellitus. An age interaction was included for all of these predictors to account for the attenuating effect of these risk factors with increasing age. On this slide, all coefficients from the SCORE2 OP model are shown graphically. What can be seen is that there's a different coefficient for men and for women for every risk factor, and that the effect of the risk factors indeed attenuates with increasing age. This model was then recalibrated to 4 European risk regions using nationally representative registry data. Those risk regions were grouped upon age and sex standardized CVD mortality rates as reported to the WHO by every country. The regions are the same regions as used for SCORE2. For the external validation of the SCORE2 OP model, 6 contemporary datasets were used. 3 of those were prospective cohorts, the MESA, ERIC, and CPRD study, and 3 international trials were used, the HIVET, PROSPER, and SPRINT trial. In total, over 300,000 individuals were included, and we observed over 2 million years of follow-up. And in that time, we observed over 30,000 fatal and non-fatal cardiovascular events. External validation of the SCORE2 OP model showed adequate discrimination in all external validation cohorts. Discrimination ranged from 0.63 in the combined population of all trials up until 0.67 in the ERIC study. The SCORE2 OP model was used to derive these two-dimensional risk charts. These charts can be used very easily in clinical practice to predict the risk of cardiovascular disease. There is one chart for every region, and they are colored like the SCORE2 region. Do note that the coloring is slightly different for older persons due to potentially different treatment targets in the older persons. As this may be very relevant to discuss cardiovascular disease risk at a shorter time horizon, we also developed 5-year risk charts for every risk region. However, the model can also be used online, which also has some very important advantages, which I will demonstrate with a patient example. For example, you have a 75-year-old woman in front of you. She is from the Netherlands, in the low-risk region. She's a smoker, she has no diabetes, she has a blood pressure of 140 millimeters mercury, a total cholesterol of 4.5 and an HDL cholesterol of 1.4. Using the SCORE2 OP model, recalibrated to the low-risk region, her 10-year risk of myocardial infarction, stroke, or cardiovascular death would be 14%. An important advantage of using an online calculator is that you can easily combine this with treatment effects. For example, we can calculate the risk of her predicted benefit of 10 millimeters mercury blood pressure reduction. For this woman with a 14% 10-year risk, her absolute risk reduction would be 2.6, and also her individual 10-year number needed to treat would be 38. This can also be really helpful to communicate the potential treatment benefit of risk factor reduction in clinical practice. In conclusion, the new SCORE2 OP model estimates the risk of fatal and non-fatal cardiovascular disease for older persons, and this model has been recalibrated for use for European risk region. And individual predictions from the SCORE2 OP model can be used to inform shared decision-making. For more information, you can read the SCORE2 OP manuscript, which has recently been published in the European Heart Journal. Thank you for your attention.
Thanks very much, Stephen, for presenting this older person risk model. So the paper is open for discussion, and I have a look around in the faculty for any questions. And maybe I can kick off. So this is a competing risk-adjusted model. How important, Stephen, is it that it's competing risk-adjusted?
Thank you a lot, Professor Visser. I think especially for the SCORE2 OP model, it's very important to take the possibility of competing events into account. The risk of non-cardiovascular mortality in older persons, especially in the very old, is really high. And not accounting for this will dramatically overestimate the cardiovascular disease risks. And with that, if that's not accounted for well, it may lead to over-treatment in the elderly who already suffer from a lot of polypharmacy.
Okay. Any questions?
Quick one, if I may. Everybody wants to have reasonably up-to-date cohorts. There's got to be a lag, of course, to allow follow-up. On the other hand, with the older cohorts, there was far less co-intervention with statins and with antihypertensive treatment and so forth. Would you like to comment on that issue?
Thank you, Professor Graham. That's indeed a very important issue. On one hand, indeed, we want to have the most recently available rates as possible, but on the other hand, the data from before 1990 probably, it would be a lot easier to use because a lot less people are being treated by then, and all factors used are the untreated factors. However, that's not that would be on one hand a bit easier, but we really want to make this score as applicable as possible. Many individuals, especially from age 70 on, are already treated for either their blood pressure or their cholesterol. So we do need to include those individuals both in model derivation and in validation, because they are a very important group in which potential further therapy initiation is considered.
Thank you.
If I can make one small remark about it, if you want to use this model in practice with patients who are just treated on the risk factors, you really should take care when interpreting the results, because the predictions are to made with patients who have been on stable treatment for quite a long time. So do take care when just initiating treatment.
Yeah. So what do you think is a reasonable time period for treatment? 3 years, 4 years, 5 years, 1 year?
Yes, that's an excellent question. I have not looked into detail of this, but I would say at least a few years of stable therapy.
Okay. Time for a last quick question.
Is it then that you take the previous data, then the results of cholesterol levels before taking medication? Is that what you then include into the risk estimation?
No, I would just use the most recently available data you have, but you have to take a bit more uncertainty into account when you use these in clinical practice. Especially, but if you started a few days ago, yes, you should probably take the pre-treatment values. If you have been treating for 1 or 2 years, take the most recent values available, but interpret them with care.
Okay, thanks very much, Stephen. We are moving towards the end of this session, and it's time for some concluding remarks. And who's the best person to do that? And that's, of course, Ian Graham, the founding father of the SCORE legacy, I would say. So Ian, please, for your concluding remarks.
Well, thank you so much to all the faculty. I hope we've given you some idea of how we've struggled over the past few years. There will never be a perfect risk estimation system, but we are trying to address some of the key issues. What I have to say now will bring us in the full circle, because it relates to the work we've been doing with the Cardiovascular Risk Collaboration set up in the European Heart Health Institute in 2020, co-chaired by Emanuele and my good self. And I would just point that it's a partnership. It's interested in partnerships and coordination, not in controlling things. This is a slight modification of the diagram that you've seen already. You'll see at the bottom the outputs. We've talked about SCORE2 and SCORE2 OP particularly today, but we're also interested in integrating other risk markers, diagnostic tests, improving interactivity, developing true lifetime risk and personalized risk. And you'll see from the top of the diagram, we're also interested in other diagnostic groups, not just coronary heart disease and stroke. So for the immediate future, we are not privy yet to the final version of the prevention guidelines, but we understand that SCORE2 and SCORE2 OP will inform these guidelines. And we hope that we've developed significant improvements, much larger derivation and validation cohorts, total events, fatal and non-fatal, risk estimates, as you've heard, adjusted for competing risks, extension to older people, and the calibration for 4 risk regions of Europe, with the potential for country-specific charts for the future. In the longer term, we are looking at newer approaches to lifetime risk with Brian Ferencz and others. For example, will developments in Mendelian randomization really bring us substantial advantages over what we can already do? So that's something that's of great interest to us at the moment. We have to integrate better newer risk factors and imaging. We need to improve the interactivity of HeartScore, the electronic version of SCORE2. And we need to also explore further artificial intelligence and machine learning to try and look objectively at how these can allow, for example, more flexible and frequent updates to risk estimation. So we felt at the beginning of this process, one of the reasons for the collaboration, we felt that risk estimation had become maybe a little bit static. And there are certain limitations which we don't want to rehearse anymore at the moment, but we are entering an era of new concepts and new collaborations. So we're looking at new regional total risk charts, extending risk to older people, risk in specific person and patient groups like heart failure, atrial fibrillation, and so forth, adding in new risk markers and imaging, and also to our next immediate step is to start exploring true lifetime risk and how risk estimates in young people can be personalized. And in parallel, we'll be looking further at artificial intelligence and at machine learning. So the CRC is not any kind of exclusive club. And if any of these aspects are of interest to you, please contact us, and we will be very interested to get thoughts and help and advice from anybody. So it is my pleasure then to conclude this session, to thank all of the speakers, particularly Frank and Martin Halle and Lisa Emanuele, and all the participants. And thank you indeed for your attention.